I'm Dr. Julie Rodman, and for this quick 10-minute session, I'd like to discuss with you what happens when the vitreous doesn't behave, give you a quick OCT guide on epiretinal membrane and some associated complications. So, whenever I do an OCT lecture, I emphasize the importance of understanding the retinal anatomy. You can't understand really OCT or vitreomacular interface disease, or really any retinal disease, if you don't understand retinal anatomy. So, when you're looking at this histopathological slide of the retina, the area of emphasis for this little bit of presentation we're going to do is going to be the vitreoretinal interface, which I have enclosed in that black box. So, the vitreous lives above the inner limiting membrane. And then we know that the sensory retina, photoreceptors, RP, Brooks membrane, choroid, choriocapillaris all live below the vitreal interface. What's important to keep in mind is that even though we think about the vitreous as a very superficial part of the retina, part of the retinal anatomy, it really can affect any part of the retina, really depending on the amount of abnormality that we encounter. If you were to transpose that slide onto an OCT, this is essentially what you would see. So the area of emphasis is going to be this black space on top, which is our vitreous. And as we all know, it's very abnormal to see an OCT that has such a beautiful black space because as we age, things are going to begin to happen within that vitreous body. And we're going to talk about that in just a minute. Some areas of importance, obviously the hyperreflective band here, or the inner limiting membrane, which is what separates the vitreous from the underlying retina. And remember the word posterior hyaloid. Posterior hyaloid is the most posterior aspect of the vitreous body, which essentially lives right up against the inner limiting membrane of the retina. Then we have our nerve fiber layer, ganglion cell layer, and then we have, again, the substance of the retina, or the sensory retina, which takes turns between the plexiform and internuclear layers. The plexiform layers tend to be hyperreflective, the nuclear layers tend to be hypo. So we have the inner plexiform layer, which is hyperreflective, the internuclear layer, which is hypo, and then the same thing, outer plexiform, outer nuclear. Then we have our external limiting membrane, which is a fine powdery line that should be visible in healthy individuals. We have our photoreceptors, or IS, OS, inner segment, outer segment junction of the photoreceptors, which is a super important line on the OCT. That's this one right here. We have our interdigitation zone, where our cones are most densely packed. We have our RPE, Brooks membrane, choriocapillaris, and choroid. So for purposes of, today's conversation, we're going to focus a lot on that vitreomacular interface, but pay attention also to this, what I call sweet spot on the bottom of the OCT. Because remember that when that area is obstructed for any reason or not normal, patients by definition may not have good or 20/20 vision. So let's jump right into the vitreous. We know that as we age, there are two things that happen to the vitreous. We have the synthesis, or the liquefaction of the vitreous gel. Remember that when you're born, the vitreous is like a body of jello. And as we age, the collagen beams that keep that jello together will begin to liquefy, fall apart, break apart. And this is just kind of a schematic of what that might look like on a picture. Then we have the syneresis, or the contraction of the vitreous gel, which is really that anterior displacement, as you can see here, of the vitreous migrating forward. So these two processes of synthesis and syneresis are normal. They're things that happen over the course of a patient's life. Here's another picture of what this liquefaction might look like. You can appreciate these lacunae, or fluid-filled pockets, that are forming within the vitreous body. And on OCT, what you'll notice here is what we talked about, that white stuff, right? You're going to begin to see the collagen fibrils, the breaking down of those beams floating around within that black space. These little areas within that vitreous body are these lacunae, or these liquefied areas of vitreous. So this is normal, right? This is what should be happening. The other process is that syneresis, or the anterior contraction, which you can see on the picture here, where the posterior hyaloid is breaking away from that inner limiting membrane. And on the OCT, it's really beautiful how you can see this whole anterior displacement of the vitreous body. Two different, forms of the same type of thing happening. So as the vitreous does its job, as it liquefies and contracts, a PVD is happening. So there's different stages of PVD, and what I like to say when I'm teaching about PVD and OCT is, it's not super important in the earlier stages of PVD, but as we get closer towards, a stage 4 PVD, it becomes more important really for purposes of symptoms. What I mean by that is in a stage 1 PVD, you can see that the posterior hyaloid, that where the white arrow is pointing, is beginning to lift up temporally. And that's really the only location there of abnormality. There might be stuff floating around in the vitreous as well, but the part where the posterior hyaloid is lifting up off the inner limiting membrane is really just in one location. So we define that as a single quadrant of perifoveal detachment because it's around the foveal area. In a stage 2, what you'll notice is now nasally and temporally, that posterior hyaloid is lifting up. So we call that 360 degrees of perifoveal detachment. And as I said before, there can be other stuff happening at the same time because remember that the liquefaction and the contraction are going to happen in the process of PVD formation. In a stage 3, the vitreous has detached from the fovea, from the macula, and is only attached at the optic nerve head. This argues to the importance of getting a wide field OCT where you can visualize optic nerve and macula at the same time, because if you can't see the optic nerve, you can't assess whether or not the vitreous is still attached there. So in a stage 3, the vitreous is still attached at the optic nerve head. In a stage 4, we know that the vitreous is fully detached. There's no more connection to the retina. So it's detached from the macula, detached from the nerve, visualizing as a Weiss ring clinically on exam. If the OCT is completely black in the vitreous space, that might be an indication that there has been a PVD, but that vitreous has migrated so far forward on the OCT scan that we do not see it clinically, or we do not see it on the picture. So remember, when the vitreous does what it's supposed to do, synchesis, syneresis happens simultaneously, and we get a posterior vitreous detachment. However, what happens when the vitreous doesn't behave? What happens when things don't progress as they're supposed to? Well, that's when we start to worry about things like epiretinal membrane. So if the vitreous is trying to detach from the inner limiting membrane, but it's not doing a very good job, if you want to say, some of the vitreous debris can remain on the surface of the retina and proliferate. And when that proliferates, it leads to proliferation of the glial cells on the inner limiting membrane in this contractile force. So we get an epiretinal membrane formation or proliferation of glial cells on the surface of the retina. And what you can appreciate here is that this vitreous is kind of trying to detach, but leaving remnants behind. Clinically, this is what an epiretinal membrane would look like. You get this glistening, this cellophane maculopathy, this wrinkling of the retina. There may be distortion of the underlying vasculature depending on the severity or the category of the epiretinal membrane. This is a beautiful picture of a patient that has a well-delineated epiretinal membrane with a clear vitreous, meaning that they likely already had a complete PVD. But guess what? This patient might be 20/20 because remember what I said at the beginning. If this sweet spot or the photoreceptor integrity line at the fovea is intact, the patient may still have very good vision and may not even notice that they have an epiretinal membrane. The picture on the bottom right is an en-face image where we cut tangentially through the retina, allowing for better visualization of the epiretinal membrane. Here are some more kind of examples of what epiretinal membrane may look like. You may see just a very solid line right across the surface of the retina with this tangential traction, allowing for a thickening or broadening of the sensory retina. And you may even see some splitting or dehiscence within the sensory retina. This picture shows what we call sawtoothing or some abnormality to that inner limiting membrane as a result of that abnormal vitreous detachment, with again some separations here within the sensory retina. And then a beautiful picture here of a patient that has a complete PVD and really a nice example of a big epiretinal membrane causing some vitreomacular traction. I want to remind you again that the patient's vision in all of these cases may still be preserved due to pretty good looking, ellipsoid zone or photoreceptor integrity line areas. I love this picture because this is another, you know, pretty significant epiretinal membrane that resulted in a pseudo hole formation We're not going to go into holes in this conversation, but just pay attention to other things that could happen as a result of epiretinal membrane and anomalous PVD. So risk factors for epiretinal membrane, remember, as we get older, we're more prone to getting these. Great patients greater than 50 years of age, about 2% have ERM. And then look what happens when you're greater than 75, it's 20%. So as a result of getting old or older, you're at risk for getting epiretinal membrane. In about 10 to 20% of cases, the patients will have bilateral epiretinal membranes, which may vary in severity. So the question I'm asked all the time, Julie, what do you do for epiretinal membranes? Do I need to refer every single one? The answer is no. Remember that if patients are asymptomatic and they're just walking around with this, which is usually the majority of the cases, you can monitor. Okay. However, if patient's vision is affected, usually worse than 20/60, or if the patient is experiencing symptoms such as metamorphopsia, diplopia, that is when a referral is recommended. The treatment of choice is usually vitrectomy with an inner limiting membrane peel. 80% of patients with ERM or VMT will improve by at least 2 lines following vitrectomy. So if patients fall in this category, or if they're very symptomatic, certainly refer. I wanted to end my short little conversation with you guys about a patient I actually just had this past week. She was a 58-year-old Hispanic female who was asymptomatic. She came in with 20/20 vision in both eyes. On clinical observation, you'll note that she definitely had an epiretinal membrane there. You can see the tractional bands, the folds there. And also, I noticed that inferior, she had some elevation of her optic nerve head. And I wasn't 100% sure what was going on. So I said to the student, let's get an OCT. But her other eye was even more impressive. Here she had what I like to call the case of the displaced epiretinal membrane. The epiretinal membrane was not sitting over the fovea, it was sitting between the optic nerve and the macula. And still, there was some abnormality to that inferior optic nerve head tissue. So we jumped right in and got some OCTs. On the right eye, remember to always look at sequential images on your OCT and not just look at one scan. Kind of going through these, you'll see that this patient had, this is the posterior hyaloid. She had a little bit of vitreomacular traction. She certainly had an epiretinal membrane right here. But what was most interesting is that this vitreomacular abnormality was actually putting some traction on the optic nerve as well, resulting in kind of this pseudo-papillodematous appearance. So we need to be cautious that not only can patients' epiretinal membrane result in a vitreomacular traction, but you could also get vitreopapillary traction. So nice example here of not only the vitreous being attached, to the epiretinal membrane at the macula, but also causing distortion at the nerve. And these are some more images here of the patient's right eye, where you can see that vitreomacular traction. You can see the abnormal kind of sawtoothing here. And this doesn't give you the same, view of the optic nerve, but gives you a really nice example of what the epiretinal membrane is doing at the macula. The other eye, similarly, you can see the epiretinal membrane sitting between the optic nerve and the macula, but look again at how we like to call it the displaced ERM, because it's not sitting at the macula, it's sitting in that space between the optic nerve and the macula, and also causing that traction on the optic nerve head, resulting in that pseudo-papillodematous appearance. And some more images here. So again, you can see the epiretinal membrane here. You can see how the posterior hyaloid is just pulling right on it, and again, causing that traction on the optic nerve. So this was a patient that was asymptomatic, came in for routine exam. We happened to find this. So I just, explained to her that if she starts to develop any symptoms, that she certainly should come back. Otherwise, we're going to see her back in about 6 to 8 weeks, just watching to see if she does develop a complete PVD, or if she develops any other complications from this impending PVD and vitreopapillary and vitreomacular traction. So thank you so much for tuning in for this short episode on epiretinal membrane. I hope you enjoyed it and look forward to seeing you at future webinars.